Hello, everyone. My name is Rhonda Anderson. I'm one of the level 4 faculty, and I'm going to be speaking with you today about brain tumors. So allow me to share my screen, and we're going to jump right in. Now, brain tumor starts on page 1318 in your Lewis 11th edition textbook. Starts down here at the bottom. So brain tumors, we estimate there's about 2,400 or 24,000, excuse me, people diagnosed each year with brain tumors in the United States. Males have a slightly higher incidence of brain tumors than females, and they most often occur in middle-aged persons, but they can be seen at any age. So when we talk about brain tumors, we talk about them being either primary or secondary type brain tumors. Primary brain tumors, usually known as gliomas, originate in the astrocytes, but we can also have other types of brain tumors. 65% are primary brain tumors, which it means it's the original tumor. So these can be glioblastoma multiforme. These are the most common forms of the gliomas. Can be a meningioma, a tumor of the meninges, the tissue surrounding the brain, and it's the most common primary type. And then astrocytomas. The meningiomas are usually benign, but depending on where they're located, may limit us in our treatment. And astrocytomas are tumors of the supportive tissues or the glial cells, and they can range from anywhere from low grade to moderate grade tumors. The glioblastomas are primitive stem cells. They're highly malignant and highly invasive, and the most devastating of the primary tumors. These often are described as like having tentacles. So they're very rapid growing tumors, and they can be very deep inside the brain. Your secondary type cancers, brain tumors, are metastatic brain tumors, and that is the most common type of brain tumor. These are tissues or tumors that metastasize into the brain from lung, breast, and bone being the most common. Now, more than 50% of brain tumors are malignant and are not amenable to complete removal. Others, they may be histologically benign, like we were talking about with the meningiomas, but because of their location, prevents complete removal. So the astrocytes, these are the glue-like cells that are the supportive tissue of the brain. Here you can see a picture of a rather large astrocytoma. The meningiomas, this is one on the coverings of the brain, the meninges, again, will be a space-occupying lesion, but usually benign. And then the glioblastoma multiforme are one of the more devastating, and you can see this large tumor here and how we actually have a shifting of the brain tissue across midline. Signs and symptoms of brain tumor are going to depend on the location of where the tumor is, what lobe of the brain, and which side of the brain, as well as the size of it, how much space is it taking up. The rate of the tumor growth, the appearance of signs and symptoms, all depend on, again, location, size, and the mitotic rate of the tissue origin. Seizures are very common in glioma and metastatic brain tumors, and these will be new onset seizures. And then hydrocephalus can occur if the tumor grows into the ventricles so that cerebral spinal fluid flow is obstructed. We'll have alteration in the function controlled by the affected area. So if it's temporal or parietal areas, you may see memory problems, mood, and with right frontal, you may see some behavioral changes. Muscle weakness will be contralateral to the side where the tumor originates. Aphasias, whether it's expressive or receptive, This is usually seen in patients who have tumors in the parietal or temporal lobe. And then sensory losses will be contralateral. Patients may present with nausea and vomiting. This will be due to increased intracranial pressure. And then many will complain of headache. That's the most common problem. And they will tell you that they tend to be worse at night, and they will actually wake the patient up. And that's going to be due to the increase in their intracranial pressure. Remember, when we lay their heads down, the ICP is going to go up. They'll describe them as being a dull headache and constant. With diagnostics, we obviously want an extensive history. We want to know if they have a history of cancer that might have caused a metastatic tumor. We want a comprehensive neuro exam, and we want to make sure we've tested cranial nerves and motor function, balance, cognitive functioning, all of those things. Any new onset seizure, we have to be suspicious of, especially if they don't have a history of any traumatic brain injury. Remember, anytime you've had a brain injury, there's always a risk that somewhere down the line you could experience a seizure, even for the first time. It could be 15 years after the accident, you could have a seizure. And then any adult onset migraines. If they've never had migraines and now suddenly they're experiencing migraine headaches, we need to look into that. Or if they do have a history of migraines, this type of headache is different. It doesn't follow their usual pattern of migraine symptoms. Now, we'll do CTs, MRIs, all those are going to give us quick visualization of the size and location of the tumor. We can do PET scans. We can do an EEG, but it's not very useful in diagnosing a brain tumor, and so it doesn't have that much importance. It's more helpful if we're trying to control seizure activity. Lumbar punctures, we don't really do them anymore. They're not usually going to be diagnostic, and they carry a risk of herniation if we remove too much CSF too rapidly. Angiography can be helpful, especially if we think the origin is in any of the blood vessels of the brain. And then, of course, a biopsy. Biopsy's the only way that we can go in and know exactly what type of tumor we have, its mitotic rate, and what it might be best receptive to for treatment. So the biopsy is the primary way to tell us whether it's malignant or not, and a tissue of origin. As far as collaborative care, we have our goals are to identify the type of tumor that we have. Is it primary or metastatic, and where it's located, and then the type of tumor that it is. And then our other goals are to remove or decrease the mass, because not all will be conducive to full removal and may have to have concomitant therapy afterwards with either chemo and or radiation. And then our last goal is to manage their intracranial pressure. So surgical treatment is the preferred treatment, and that's the removal of as much of the tumor as we possibly can. There's stereotactic surgical techniques that can be used, particularly to perform biopsies or remove small brain tumors. But again, the outcome of the surgery is going to depend on the type of the tumor, the size, and its location. Where meningiomas and ogliodendrogliomas can be completely removed, our more invasive gliomas and medulloblastomas can usually only be partially removed. So the other types of treatment, whether it be radiation or chemo, will be used to shrink the size or try to kill off the rest of the tumor. But it is still the preferred treatment, like pretty much in any cancer care. Ventricular shunts are when we place catheters with a one-way valve, as you see here in this picture. We place it in the lateral ventricle, much like we do when we're doing ICP monitoring. And we tunnel the catheter so that that CSF will dump either into the jugular vein or into the peritoneum. And as you can see, this catheter dumps down into the peritoneum that allows the CSF to be drained. That will help with hydrocephalus and managing chronic increases in intracranial pressure. Radiation therapy and stereotactic radiosurgery, a follow-up measure postoperatively. And usually we're going to give them corticosteroids for the cerebral edema. After that, remember, in tumors, we definitely use steroids because it's going to decrease that vasogenic cerebral edema that's around that tumor bed. And it'll help also deliver concentrated doses of radiation precisely to the location in the brain. Chemotherapy and targeted therapies. We're not going to get too specific on a lot of these medications. It's not the purpose of this lecture, but you may see these in charts. So I've listed here some of the more common things that you may see in your patient's charts. The drugs called the nitroureas, those are like your carmustine, lomustine. They're going to be used to treat brain tumors because they can actually get into the blood-brain barrier, where a lot of these other chemotherapeutic agents will not cross the blood-brain barrier. When we look at gliodylyl wafers, what these do, we implant them at the time of surgery directly into the tumor site. Other drugs that can be used, we have methotrexate, we have procarbazine. Both of those can deliver chemotherapy via the intrathecal administration or this Ommaya reservoir like we have up here. So the physician or other healthcare provider that's licensed to do this catheter goes directly into the ventricles. You have a little area up here below the scalp that allows us to inject the medication in here, and it will be gradually, slowly distributed, and it will bathe the brain and kill the tumor cells. And then I've listed just a few others. Then we have indications for cranial surgery, and this you can find on table 5614, actually, on page 1321. So indications would be an intracranial infection or abscess, hydrocephalus, brain tumors, intracranial bleeding, skull fractures, AV malformations, or cerebral aneurysm repairs. And there are a couple of different things we can do. We can do burr holes, craniotomies, craniectomies, cranioplasty, and stereotactic procedures like we just talked about, and shunt procedures like we just talked about. The burr holes, you have opening into the cranium with a drill, and we remove a very localized area so we can take blood and fluid beneath the dura. So we use those a lot for like epidural hematomas, subdural hematomas, those kind of things. Craniotomies is when we excise into the cranium and we cut away the bone flap. But after we repair or remove whatever we're focused on, then the bone flap is put back into place. And it'll heal over time. With the cranioplasty, there's a cranial defect from the trauma or from either malformation because of tumor that's into that part of the skull. So what we do is we actually remove that bone flap and expose the dura. We take care of the lesion, we do whatever we have to do, and then we replace it with either plastic or metal. That's cranioplasty. And then a craniotomy is when we open into the cranium, we do whatever we have to do to repair or remove a lesion or drain blood or do whatever because of increased ICP. So those are some of the surgeries you may see, but our post-op care of a lot of these patients are very similar. And then we talked already about stereotactic and shunt procedures. As far as acute interventions, pre-op and post-op, it's usually the same regardless of the reason behind why we're doing this procedure. A lot of education and emotional support, helping the family and the patient understand what to expect, what the surgical procedure is going to look like. They're going to go to ICU post-operatively, may come back still with their endotracheal tube in place on a ventilator, may not, but we'll have a plan. The physician will talk to them, and then we can explain to them what all this looks like. Because when they come in, we have to kind of orient them to everything. Prevention of elevation in their ICP. So we're talking about positioning and use of medications. We want to keep a very quiet, calm environment, not a lot of stimulation. Frequent neuro assessments, especially the first 48 hours, we're going to be doing neuro checks, as well as monitoring for vital sign changes. Fluid and electrolyte monitoring, particularly paying attention to serum osmolality, looking for any problems with either diabetes insipidus or SIADH. Repositioning, making sure the head stays up 30 to 45 degrees for anterior or middle fossa. And if it's a posterior, which don't get too bogged down on that, but if it's posterior, a lot of times they do better if we keep them a little bit on the flatter side. If the bone flap has been removed and placed in the abdominal cavity so that we can go back and replace it later, and this would be to manage increases in ICP, we want to make sure that we don't position the patient on the operative side for obvious reasons. They may or may not have some type of helmet to remind everybody and to prevent any direct injury to that open brain area. It's usually covered with a sterile drape, and we'll have a bandage on it, but we don't want to position them on the operative side. Manage pain and nausea. We'll use short-acting opioids, and again, we're going to avoid Phenergan for the nausea. We're going to use the Zofran because Phenergan's too sedating. Observe for any dressings to make sure there's no evidence of a CSF leak or any kind of bleeding that we weren't expecting. Watch for drains, making sure that they stay patent and in place. Scalp care to prevent infections. We tell the patient that what we're going to do is clean the site. Usually the physician's going to change the dressing the first time, and then after that we'll give us specific orders. But once they don't need a dressing anymore, we'll clean the site per the neurosurgeon's orders. Afterwards, we'll use an antiseptic soap, and they can do that at home to make sure that it stays clean. And then once the incision has healed, then the patient can wear a wig or a turban, a scarf, a cap, whatever they want to do, and while the hair is growing back. And if they're receiving any radiation, we need to make sure that they know to use sunblock and a head covering anytime that they're out in the sun, particularly down here. The rehabilitation phase for these patients, just like with head trauma, is going to end, spinal cord injury is going to be highly individualized. The rehab potential is going to depend on the patient's underlying health, what their comorbidities were prior to this, and the reason for the surgery. The overall goal, like any other rehab, is to foster that independence so that they can have a good quality of life and be as independent as much as possible. Specifics for what their outcome is going to be will not be able to, we won't know this, and we won't really be able to give much of a prognosis from the physician standpoint until the edema and the ICP subside. So usually about 3 days, 72 hours from the surgery, the swelling should start to go down. So, within 5 days or so, we have a better idea of how well they did and if they're going to have any secondary injuries on top of what we're dealing with the tumor. So from a nursing standpoint, we're still going to continue that careful positioning, paying close attention to skin care on the contralateral side, especially if they have any hemiplegias or hemiparesis on that side. Good oral care, range of motion, especially on the affected side. Bowel and bladder care, trying to restore that to normal as quickly as possible. Nutrition, they will be a little hypermetabolic at the beginning of their care, but then they're going to need a high protein diet. But then after that, we can kind of go back down once the healing has occurred. And then referrals to appropriate healthcare providers. And this is usually going to be PT, OT, maybe speech therapy, a physiatrist might be important, maybe a neuropsychologist to help them with the psychological and cognitive part of recovery after brain tumor, and continued therapy if they have to have the follow-up with radiation and or chemo. Okay, that's it for me. So if you have any questions, reach out to your theory or clinical instructors for any assistance. Thank you for your time and attention, and I hope you have a great day.